So thank you, Washington and the surrounding area, for joining us today. I want to introduce you to a longtime friend of the Life Raft group, Dr. Sociopatris Boykos. He and I go back. We've shared a cab to the airport in Miami from an educational event that we did a number of years back. And I'm so happy to see that he's landed in Georgetown, that he's staying on the East Coast. So we're welcoming you, Dr. Sociopatris. Can you just introduce your other presenters here today?
Yes, of course.
Appreciate it.
So can you hear me?
Yes, we
Yes.
can hear you.
So it's a real pleasure to be part of this great event. As Laura said, you know, I have worked with Life Raft since my time at NIH as a fellow. Life Raft is doing a great job. So today we have some educational lectures, and I would like to present my two colleagues. First, Dr. Stevies. Dr. Stevies is a senior surgical oncologist at Weissel Hospital Center and MedStar. He completed his undergraduate degree in chemistry, and then he had a medical degree at Emory University. He was recruited at the Weissel Hospital Center, having a leadership position. He serves on the National Program Committee on Liver Biliary Diseases for the Society of Surgery of the Alimentary Tract, and he's the cancer liaison physician at MedStar Weissel Hospital Center for the Commission of Cancer, American College of Surgeons, and previously a state chair of DC area. Dr. Stevies, thank you so much for joining, and I look forward to hear your presentation.
Pleasure to be here. Hopefully I could be able to share my slides. I'm going to try this. Hold on for a second. Let me see. Diane, can you share for me?
Absolutely.
This is why I sent you the slides.
Yeah, perfect. There you go.
Okay, can everybody hear me?
Yes.
Yeah. Hi, my name is Mark Stevies. I'm, as Dr. Boykos introduced me, I'm a surgical oncologist here at the MedStar Washington Hospital Center. Next slide, please. So my talk today is on the evolution of the disease and its treatment. It's actually very fascinating. This is mostly a historical talk. It's also included in the book chapter I wrote in one of the sarcoma books about 3 or 4 years ago. The editor is one of our orthopedic oncology surgeons, Dr. Henshaw, and it details both GI sarcomas as well as extremity sarcomas. Next. So gastrointestinal stromal tumor is the most common mesenchymal tumor of the GI tract. About 4,000 to 6,000 cases per year. For those of us, for those in attendance who are mostly in the lay population, a mesenchymal tumor is a fleshy tumor. It means it's not a mucosal-based tumor. In other words, it's not a part of the lining, though it can involve the lining of the GI system. So this is a sarcoma. And the reason we started getting involved in this in the 1990s was we were a peritoneal carcinomatosis program here at the Washington Hospital Center. It was under the leadership of my senior colleague, Dr. Paul Sugarbaker, who unfortunately just retired about 1.5 years ago. So we would gather patients from around the country with peritoneal disease, meaning a disease that is spread all over the abdomen. We would be doing this for appendiceal cancer, colon cancer, but occasionally we would be doing this for sarcoma patients. So starting in about 95, 96, we accrued about 50 patients, and we wrote this up, and we would take them to the operating room, debulk them completely, and then give them a form of chemotherapy in the operating room called intraperitoneal chemotherapy. And this would usually be chemotherapy with adriamycin. But anyway, what we found is, though we did a good job of cleaning these patients out, they would recur. Now, our historical data basically points to the fact that the majority of these patients were gastrointestinal stromal patients. We did not know it at that time. We call them a hodgepodge of things, leiomyosarcomas and things like that. But gastrointestinal stromal tumors, as we now know them, started to be better classified in the late 90s. Can we, next slide, please? Majority of these tumors arise from the cells in the bowel wall, what we call the ICC cells. Basically, these are pacemaker cells of the bowel. A majority of these cancers also express a specific antigen called CD117. Next slide, please. CD117 antigen is part of a magnificent cell wall receptor complex called KIT tyrosine kinase receptors. Basically, when you activate this complex, and some mutations will continuously activate this complex, this basically causes cell proliferation. At the time that GIST was starting to be known pathologically as its own separate entity, we did have one disease process, next slide please, that was actually very familiar to our hematological colleagues, basically chronic myelogenous leukemia, or we call it CML. Basically, tyrosine kinase receptors are very important in the pathogenesis of CML. Similar mechanisms that once the tyrosine kinase complex gets activated, it forms all the necessary proteins that go into the making of CML. So targeted therapy for CML was heavily researched in the 1990s and the late 1990s. And then along the way, one drug, which we called STI 571, showed great promise. Can we have the next slide? So this is it. For chemistry folks like myself, it's actually a pretty simple molecule. There's nothing very exotic about it. All those little rings with the circles are basically benzene rings, which is what organic chemistry is all made out of, and what we are made out about. But anyway, so this is STI 571. Brian Drucker basically took this molecule. This was specifically designed by Siva Gaiji, and now that company is now a part of Novartis. That company really pushed this drug, found a niche for it in CML, and basically the initial studies and subsequent clinical studies showed a remarkable response of this drug in treatment of CML. Can we go to the next slide? And this is how it happened. BCR-ABL is part of the complex that is turned on when the substrate comes in, and when that happens, you have all those proteins that are activated and form and go on to the pathogenesis of CML. However, Gleevec in the bottom binds to this receptor site, and this is what it does also in a gastrointestinal stromal tumor. So the substrate cannot enter the kinase site, and therefore the tumor cell cannot proliferate. Next slide, please. So basically, when this drug was shown to be effective, it had I think it was a 3-month turnaround in the FDA before it was approved, which was remarkable, which led to this Time News magazine, a front page, basically that the revolutionary new pills like Gleevec are basically considered the bullets that we target cancer. I mean, it was a remarkable find and a remarkable drug for CML. However, next slide. What we didn't know was the fact that it actually was also very important in gastrointestinal stromal tumor. This is the original New England Journal of Medicine article. Basically, it's a brief report, short report that basically outlined the first patient, what we call patient 0. She turned out to be a middle-aged Finnish woman who did have some connections to the pharmaceutical industry. I don't know if it was an uncle or a granduncle, but some distant relative that knew about this drug, and they were starting to know, understand what tyrosine kinase receptors were doing in gastrointestinal stromal tumor. So she had metastatic gastrointestinal stromal tumor. She had been operated on twice. She recurred both times. After her second operation, she ended up with metastatic liver disease. So they started a trial, and she was the first person, and she had a remarkable response. So because of this short, brief report, and then subsequent clinical trials, basically the drug was then finally approved. Next slide. So Imatinib, what we call STI 571, or what we call Gleevec, was approved by the FDA in 2002 for the treatment of metastatic gastrointestinal stromal tumor. And then 6 years later, it was finally approved in 2008 for the use in adjuvant setting. Between 2002 and 2008, we would be doing a significant amount of surgical work on some of these patients with gastrointestinal stromal tumor. And it got to the point that we were operating on them fast enough. And unfortunately, they were also, some of them were recurring fast enough that some of these patients did get on the early trials in the adjuvant setting so as that we could prolong their survival. And then finally, we had other drugs such as Sutent, which I'm sure will be covered later on, that came as second line. Now we have third line and fourth line therapy drugs for the treatment of gastrointestinal stromal tumors. And I think that is my last slide.
Thank you very much, Dr. Stevens. Any questions from so far from anybody?
Here, have you found that just becomes resistance to Gleevec over time? If so, how long does this typically take?
Traditionally, it's about 1.5 years to 2 years. So when we use this, what we call in a neoadjuvant fashion, I'm sure this will be covered later on, but let's say a patient presents with a large gastrointestinal stromal tumor. Most of these are commonly found in the stomach. Let's say there's involvement of the pancreas and the spleen and a portion of the colon. In other words, you have what we call multi-visceral operation is needed. In other words, multiple organs and sites need to be resected to get this tumor out. Most of those patients will need to go on preoperative gastrointestinal stromal, preoperative GIST therapy, namely Gleevec. They can't stay on Gleevec forever. We usually like to try to operate on those people from anywhere from 1 year to 1.5 years after starting treatment, just because we know that they will recur. I mean, their tumor will become refractory. And so they will not be able to have a meaningful long-term response. But that's how we use the drug in the neoadjuvant setting. Of course, if you had disease that's inoperable from the very beginning, or you've had multiple operations and you still have residual disease and you have resistance to Gleevec, it's sometimes Dr. Boykas can probably tell us better how long it takes to breed resistance, but there are second line, third line, and fourth line therapies for you. And there are some people that we've been operating on for almost 14 years. There's one woman that we just finished. I think I did not do her first operation. I've done the 4 others. So she's been alive with disease now 15 years. The problem now is, what do we put her on? As far as we know, there's no accepted 5th line drug of therapy, but we're going to put together a cocktail for her to try to keep her disease free.
Dr. Stevens, can I make one comment? I mean, I totally agree with Dr. Stevens, what he says. Regarding the resistance, we can have what we call primary resistance, meaning that sometimes the patient has already within the heterogeneous tumor some clones which are resistant, like exon 13 or exon 17 mutations. Usually those patients will develop resistance very early. Then we have what we call secondary resistance, that patients have very little clones inside the tumor which are resistant. It will take many, many years for them to evolve. And as Dr. Stevens says, we have some patients who are on decades or for decades on Imatinib, but they do great. It is very important not to stop the treatment at any point, because that gives the chance to the tumor to evolve into resistant clones. So it's very important to keep patients on treatment. Any other questions? So would you like to proceed with Dr. Al-Refai talk? and we can also have a discussion in the end.
That would be great. Thank you.
Okay, so it's a great pleasure to present Dr. Adler Fai. So Dr. Adler Fai is the head of surgical oncology at Georgetown, and he has a strong interest in GIST. He's a very busy surgeon in metropolitan DC, Virginia, and Maryland area. And he has also a leading role in terms of research at Georgetown and MedStar, and also quality outcomes. So it's a great pleasure, Dr. Adler Fai. Thank you for joining us.
Thank you so much, Dr. Boykas, and thank you, Dr. Stevies, for the wonderful lecture that you gave, walking us through the historic perspective of just how it started very broad and now it's highly personalized. And I'd be remiss, obviously, to thank the Life Raft group for this kind invitation. We're thrilled and honored to be with you today. Dr. Boykas and the team invited me to speak about minimally to maximally invasive surgery for GIST. So I'll avoid any redundant slide that I think Dr. Boykas will cover or Dr. Stevies have covered, and focus on this perspective only. I have no disclosure to report. I think this was covered by Dr. Stevies. That is the most common mesenchymal tumor, most commonly present and prevalent in the stomach. And it has approximately equal gender distribution. Most patients will express c-KIT mutation. Gastric GIST has the most favorable prognosis, largely due because of exon 11. And then the common metastatic sites are the peritoneum and liver, and least are lung, regional lymph node, and the bone. Most patients with GIST, or persons with GIST, would present in an asymptomatic manner. And I believe that's largely due because of the higher proportions of endoscopy and cross-sectional imaging scans. So it is not unusual if they're found during an endoscopy for a different reason, during surgery for another operation. I'm sure Dr. Stevies and many of our colleagues have come across just during a different operation, an appendectomy or a gastrectomy, and it's found. And obviously they range from microgysts that are small in size to very large in size. And when symptomatic, they typically present with bleeding, pain, less likely obstruction. I think there are a few thoughts that I want to share with the team about the essentials for biopsy. Just tumors are soft and fragile. A biopsy can lead to tumor hemorrhage, and therefore an endoscopic approach is always preferred rather than going through the skin. And I think the decision to make a biopsy should be based that do we have this patient have neoadjuvant therapy by Dr. Boykas? Are we suspecting other types of conditions of malignancy? I'm of the opinion that a surgical biopsy is strongly discouraged. And at times you're unable to make a diagnosis, and we rely on a high resolution CT scan and endoscopic ultrasound, and therefore the diagnosis is made postoperatively, especially in smaller GIST that are found in the stomach. Let me share with you a few slides about the personalized risk stratification for GIST. This table was put together by Dr. Imatinib, our colleague in the surgical pathology at the NCI. Credit goes to him and his colleague about, playing up what's important in the long-term outcomes of GIST at that time, which is the mitotic index, the size, and where is it located. And as you can see, when they're small and they have very light mitosis, especially in the stomach, the risk of progression is exceedingly rare, approaching zero. And that's one of the main reasons why when we have a patient with a small GIST in the stomach that's asymptomatic, we typically offer watchful surveillance, if you will. Now, I'll share with you my thoughts around the essentials for surgery for GIST, be it minimally invasive or open operation, surgical resection remain the mainstay. For primary resectable GIST, we aim for a margin negative resection, and we would like to maintain the pseudocapsule around the GIST, because sometimes it's hard to differentiate whether this is a scar tissue versus disease as well. One has to handle the tumor carefully because it can rupture specifically after targeted therapy. So after patients who undergo Imatinib or second line, their tumors typically become cystic and soft. So I'm even more careful when I handle them in the operating room, because we're seeing more and more literature to suggest that a fracture or spillage may lead to worse outcomes. And then our community, we always try and think and keep just in the differential diagnosis when we encounter a person with a mass in the stomach or even a large mass in the retroperitoneal area. So what are the preoperative consideration? Where is the tumor located in the stomach? Is it within the stomach, outside the stomach, or both? This is a cartoon of the stomach just to give you an idea. I also place emphasis about the tumor size, and I don't have a cutoff to say this is for neoadjuvant or not. It's part of the decision making where at times, as Dr. Stevies have mentioned, if we feel that the mass is large and invading surrounding structure, this is a perfect case for upfront targeted therapy in those cases, and therefore those patients will get axonal mutation and followed by preoperative targeted therapy. Another consideration is the patient's body mass index, and then, as I mentioned, consideration for neoadjuvant.
Okay, great.
So what are the approaches for resection? One is a laparoscopic endoscopic resection. So our team is liberal in using upper GI endoscopy at the time of surgery to better locate the tumor, and we combine that with laparoscopy. At times, if it's in the lumen and near the pylorus of the stomach or near what we call the gastroesophageal junction, probably this case is more amenable for laparoscopic assist with intraoperative endoscopy. And then if we're unable to accomplish that, then we switch or extend the incision to open, and at that time the incision is not very long. So that's the graded approach that I adopt in those cases, unless I think the location dictates a laparoscopic assist approach. The most important thing that I want to share, and I'm confident that Dr. Stevies and Dr. Boykus agree that the essence here is a safe and oncologically sound surgery. And in order to do so, I believe in intraoperative endoscopy. It allows us to better assess the tumor. It also allows us to avoid narrowing the stomach if a stapler is to be used, ensure adequate resection. And if you believe in that it helps identify and test for leaks. An intraoperative frozen section is helpful. And then be flexible in switching from one approach to the other, i.e. from a laparoscopic where you can add a hand port and it becomes a laparoscopic assist, and if not, extend to an open operation. So this table just gives you a flavor of how location and where is it in the lumen adapt how we use laparoscopy or laparoscopic assist. So one of the most favorable location is greater curvature on the front of the stomach is really a ripe location for laparoscopic resection. Lesser curvature because of the two nerves that supply the stomach. I favor a laparoscopic assist in those situations. Intraluminal, I'm typically careful about laparoscopy only. I typically would use laparoscopic assist, especially around the lesser curvature. If we have tumors near the GE junction, those are tricky ones as well. So if it's of a certain size, I'll work with Dr. Boykus and discuss the case in a multidisciplinary manner, whether imatinib up front or consider doing a transgastric approach where we open the stomach and remove it from the GE junction area. Likewise for the pylorus as well. And now moving outside the stomach, which is the common area, the most common area to the small bowel, I believe that they can present in one of two manners. One, that they're free floating in the abdomen, they're not attached to other organs, and it can be a good case for a laparoscopic assist through a small incision. However, one has to be careful. I go back to the handle the tumor with care. If it's attached to surrounding structure, then the incision has to be extended. And the rule that I follow is that the length of incision is longer than the tumor itself to ensure that we don't rupture it trying to pull it out of the abdomen, if you will. Likewise for the colon, which is less common if it's localized, a colon resection first if it's invading surrounding structure, then preoperative tyrosine kinase inhibitor. And I view that the esophagus and rectum are ideal location for preservations of organs and strong consideration for neoadjuvant tyrosine kinase inhibitor, if at all possible. So I'll share with you a few cases. One, this is a 60-year-old healthy woman with a good performance status who presented with a bleed requiring 3 units transfusion. This is the cross-sectional imaging, which was done. You see a mass in the greater intraluminal and within the stomach that presents in the top and middle third of the stomach, if you will. This is an intraoperative or an upper GI endoscopy. You see the ulceration on the surface of the stomach of the mass itself that led to the bleeding. A biopsy was done that showed c-KIT positive GIST. This patient underwent the laparoscopic partial gastrectomy. As you can see, the staple is away from the tumor. This was a favorable location along the greater curvature, and it was within the intraoperative, within the middle third of the stomach. And staplers always make the specimen look much smaller. So I typically like to open the specimen and the pathology to ensure that the margins are negative. And you can see there's grossly negative margins. And here's the final pathology, which was 4.5 centimeter c-KIT positive, just with high mitosis and no necrosis. And I'll defer to Dr. Bokas at the end of this talk, whether this patient would benefit or not from adjuvant tyrosine kinase therapy. This is a 42-year-old healthy individual whose good performance status, had progressive tiredness and fatigue and drop in hemoglobin, had a colonoscopy, which was unremarkable, and then had an upper GI endoscopy, again, was found to have a mass. I bring this case again and again because this case made me rethink my approach and worked very closely with Dr. Levy, who was kind to introduce to us the Japanese protocol of the gastric protocol CT scan within MedStar itself. As you can see, those are nice, highly defined, crisp CT scan. The stomach is distended, the tumor is within the stomach, sitting on the lesser curvature. And I felt this case is amenable for laparoscopic assist because of my concerns of the vagi nerve that supply the stomach. And this patient had a laparoscopic assist, then a post-resection endoscopy, did well afterwards. This is the third case of a patient who presented, 74, healthy, had again bleeding, upper and lower GI endoscopy, followed by a CAT scan that showed a mass in the intestines or close to the intestines with some air in it, which makes me think that there's communication between the mass and the lumen of the intestine. And this goes back to the table that I shared with you, that this patient had a biopsy because of concern of whether this is a lymphoma or not. It turned out to be a GIST. I perform a laparoscopic assist mini laparotomy, so a small incision. The mass was removed, negative margin, and the final pathology showed a small GIST, if you will. I'm going to pause here and share with you that there's MIS, which is minimally invasive surgery, and I think Dr. Stevies will agree there's another MIS that he and I believe in, maximally invasive surgery. I don't need to convince anyone that this is a tumor that's not amenable for minimally invasive surgery. This is a patient who had a mutation of 842V. Dr. Boykas at that time, the other lines of targeted therapy were not available, and progressed on first and second line, and then ended up having a cytoreductive surgery afterwards. Keep in mind, at times we come across undiagnosed GIST or just in an unusual location or situation. So I'm always careful, and I'm sure Dr. Stevies and other surgical colleagues, to handle GIST with care near the GE junction or the pylorus. At times you go in and you find out that the tumor probably is larger than what the CAT scan appreciates. And that can happen about 10% of cases where there's a discordance between what the scans have shown and what you find intraoperatively. And I think this is an opportunity where one would take a step back and ask, is multivisceral resection a good idea, or proceed with preoperative targeted therapy, which what I favor in general. At times, surgery is offered without a preoperative diagnosis, especially around 20%. This happened with gastric masses. It looks like it comes from the muscularis propria. Radiographically, it looks like it just as well. And obviously, it has to be discussed in a multidisciplinary manner before you move in that direction. Also, think of others. At times, if it's an ulcerative mass that comes from the stomach only and not invading the deeper part, one has to think of adenocarcinoma. If there are a fair amount of lymph nodes, one has to think of lymphoma. I bring this slide up as a reminder to discourage surgical biopsies or biopsies outside endoscopy, because it leads to tumor spillage and fracture and higher risk of resection. This is a nice nomogram that my colleague, Dr. Gold, has published many years ago from MSKCC, and we use with patients in the clinic after resection to project what are the recurrence-free survival after resection. So in summary, surgery and surgeons play a critical role in treating gastrointestinal stromal tumors. Margin negative resection is important. I believe that a watchful surveillance is appropriate in low risk asymptomatic, just under 2.5 or 3 centimeters. Minimally invasive surgery is an oncologically safe option, and I'll say with a premise in select patients, and one has to commit to multidisciplinary GIST care. Thank you so much for the honor and the opportunity to be with you today, and I welcome any question now or after the session.
Dr. Alderfai, thank you so much for your great presentation. Any questions?
There's some questions that were typed into the chat, so I'm happy to share those questions.
Sure.
Can patients who have been on Gleevec for 9 to 10 years consider cutting their dose from 400 to 200 milligrams?
So I'm going to answer that because usually I prescribe the Gleevec, but I'm sure that Dr. Alderfai, Dr. Sivis have also their own opinion, so they can chime in. If the patient do not have any side effects, I would prefer not to cut down the Gleevec because we do everything based on trials, and the trials were done with that dosage. So nobody really knows what will happen if we cut down the Gleevec. So it is the unknown. I have to say that there are some data about 13 years ago measuring Gleevec levels in the blood. And I have to say that some oncologists do that, but actually this is not proven that it has any benefit for the patients. So I would say that I would keep the 400 unless there are side effects.
Great, thank you. How does proton therapy compare to resection?
Dr. Alderfai or Dr. Stevens, do you have any comment on that?
Mark, do you want to take this on, and I can comment?
Well, I mean, I think the mainstay, can everybody hear me? Let's see.
Yes.
Yeah. The mainstay of treatment for gastrointestinal stromal tumor is surgery, along with Gleevec or Sutent or any of the other tyrosine kinase inhibitors. I mean, if you are not a surgical candidate or can't tolerate Gleevec, I guess you could rely on radiation therapy. But these tumors are not very radiation sensitive. Now, I don't know, Keith Unger is our colleague at Georgetown. He has a proton therapy program. I'm not sure that he's treated any. Maybe Dr. Alderfai can tell us. But in other words, we shouldn't really look at radiation therapy as kind of being a mainstay treatment for a major hitter in terms of treatment for gastrointestinal stromal tumors. In maybe some small fraction of patients, yes, maybe, but I would think that probably these are traditionally thought to be radiation therapy not sensitive?
Thank you, Dr. Stevens. I tend to agree with you, and not to speak out of place with Dr. Unger not with us, but we don't view them as radio sensitive, and therefore it's not offered in those scenarios.
Any other question? Hi, Sarah.
Yeah, I just want to comment on that. We actually had a virtual tumor board this morning with some interesting cases, and there was a case of a rectal GIST, and I think that there's some case studies about radiotherapy working with that, but like some of the commentaries from the tumor board members were maybe that just stabilizes it for 6 months and medical therapy is still encouraged. So perhaps in certain cases or certain subtypes or locations, it could be helpful, but obviously each case is unique.
So just to add something on what you say, Sarah, I agree with you. So I think what Dr. Alderfai and Dr. Stevens pretty much they say that this is not the standard radiation, proton, or traditional, is not the standard curative approach. But actually, we have many cases of patients doing very well on Gleevec for many years, but then they have one area growing, and then we're trying to be creative, and we're thinking of chemoembolization, we're thinking of cryoablation, radiofrequency ablation, and radiation and proton treatment have a role because they can stabilize the disease. And of course, if something is unresectable, this is something that we need to try. So there is a role, but it's not the upfront curative that replaces the surgery.
I agree.
Great, thank you. I have another question here. Can you explain the importance of mutational analysis in Gleevec in sensitive types such as NF1?
That's a great question in order for me to start my talk.
Excellent.
Because it's pretty much half of my talk. So should I share my slides?
That would be great.
Okay.
Yes.
Okay, great. So thank you very much for organizing this. I'm a medical oncologist. Actually recently moved from VCU, Virginia Commonwealth University, to Weiss Hospital Center in Georgetown, and being previously at NIH and Johns Hopkins. So I'm going actually to talk about the treatment options based on genetics. So the last question was great. I have no disclosures to make. I'm going to start saying that the most important thing for sarcoma and GIST approach is to have a multidisciplinary approach. Actually, here at the MedStar system, we have a great network of surgeons and all the other supportive areas, dedicated sarcoma pathologists, great nurse navigators, in order to be able to approach the treatment in a multidisciplinary way. So as a cancer center, we focus not only on patient care, but also on education, prevention, and research. Actually, this GIST day of GIST learning is very important for us because we educate ourselves and we educate also patients, and we answer all these wonderful questions. So that's a photo of a big exophytic tumor located on the greater curvature of the stomach. GIST can be very big, but we can have also multifocal GIST, as you know. There is some redundancy with our previous speakers. It's the most common sarcoma of the GI tract. It is arising from the Cajal cells, which are the pacemakers of the GI tract. We have about 5,000 cases. So the majority is in the stomach of the GIST, but we have 25% of small intestine, and pretty much we can have in any other location of the GI tract, including the GE junction. And as we are going to say later, this is very this is specific based on the specific genetic defects. So does chemotherapy works? Chemotherapy doesn't work for GIST. Here we have a number of trials, and you can see that there is a very disappointing partial response. So there is no role for chemotherapy in gastrointestinal stromal tumors. So I'm going to jump here and say that GIST is very gene-driven. All types of gastrointestinal stromal tumors have some specific genetic background. And I'm going to talk more in the next slides about that, but I wanted to give you an idea that the vast majority, 75%, is c-KIT driven. Exon 11 is the majority of that, and then we have a couple with exon 9. Then we have PDGFRA mutations, and the vast majority, more than 50%, is the exon 18, the D842V, that we didn't have good drugs until recently. And then we have a 10 to 15% of what we used to call c-KIT PDGFRA wild type GIST. And this is a group of heterogeneous GIST. And actually, I'm going to talk about the NIH GIST clinic and the fantastic work that has been done in characterizing further this wild type GIST. I have to say that most patients have sporadic mutations, but we have some rare cases that we can have what we call germline mutations. So there are at least 3 familiar GIST. One is the familial, what we call familial GIST. This is due to c-KIT and PDGFRA mutations. It is in patients with about 50 years old. It is multicentric, autosomal dominant. And in these families, actually, we can see many members having GIST. We had the family at Hopkins that had more than 10 patients with either GIST or mastocytosis, which is also c-KIT driven. They have also hyperpigmentation and dysphagia. There are no
Dr. Boyce, we can't hear you.
He froze.
Yes. I'm hoping that he can hear me and perhaps,
I'll send him a message.
yes, thank you. So while we're waiting. Okay, here we go. Sarah, did you want to jump in?
Yeah, I have a question for the surgeon. So there was a paper that recently came out. I mean, I know that Dr. Boykas was just talking about certain mutations. He was just going in there, but there was a recent paper that came out from Dr. Jason Siklik at San Diego regarding, based on where that tumor location is, getting a sense of what the mutational type would be. And I'm wondering, in your own practice, if you've been able to see that yourself. And if not, that's okay.
Yeah. Dr. Stevens, do you want to answer the question? I don't see him on the call. I'm happy to take the question for you. Yes, I'm familiar with Dr. Siklik's paper. It's a very, very nice paper. I think and I agree with the findings, and I've seen that over the last 15 years, that what drives outcomes in a positive or not, if you will, is location. But I do believe that the mutation analysis is part of that equation, which goes part of the location. So I think in the stomach, One of the reasons that patients with GIST of the stomach do well, in addition to size and mitosis, is that the axonal mutations are the favorable one, if you will, compared to let us say duodenal GIST or small bowel GIST, which the mutation is different. So I'm in agreement with what you think, and then Dr. Sicklick's paper. I have a bias. I train at UC San Diego, so I have to say good things about San Diego.
Did you guys go, were you there together?
I was there prior to him. Yeah.
Great, thank you. Dr. Boykas, can you hear us now?
Yes, can you hear me?
Yes.
I'm
Wonderful.
sorry about that technical difficulties.
It's okay.
Okay, let me try to. Can you see my screen?
Yes.
Okay. Okay, let me see. Which was the last slide? I think I was here, right?
Yes.
Okay, so the Cardinality Syndrome is due to mutations, germline mutation to SDH, B, C, and D subunits. And then we have neurofibromatosis type 1. This patient can have either solitary or multicentric tumors. They're older, autosomal dominant, and they can have also café au lait spots and neurofibromas. So I will start with the c-KIT and PDGFRA subunits. These are two dimers on the surface of the cells. And as you can see here, the exon 11 is the more prominent. What is happening is there is an activation due to phosphorylation. Imatinib actually is able to block this activation. So the last few years, we had tremendous actually progress. 2000, we had the first patient, as Dr. Stevens mentioned, treated with imatinib. Imatinib was approved in 2002. Sunitinib in 2006 as a second line. We approved imatinib for adjuvant treatment, where we're going to discuss what are the criteria, 2008. Then 2012, we decided that 3 years of adjuvant treatment is better. Regorafenib is the third line, which was approved 2013. And the last actually 2 years, we have 2 approvals. We have Avapridinip, which is approved for previously resistant mutation in exon 18. And we have also Ripretinib, which is approved as fourth line for GIST. So a few words about imatinib. So it was approved 2002. It has a clinical benefit rate of 80 to 85%. The median progression-free survival, as Dr. Stevens mentioned, is 18 to 20 months. But actually, we have many patients who are doing well with stable disease for even decades. 2008 was approved as adjuvant treatment for 1 year, and 2012 for 3 years. Here we have a couple of clinical trials of imatinib and metastatic GIST, and you can see here some impressive overall response data, 71%, 63%. We don't have that many patients having complete response, but most of them have at least partial response or stable disease. What is the optimal doses for imatinib? So we had that trial actually comparing 400 milligram versus 800 milligram. And they did an analysis based on the exon 9 c-KIT mutated versus everybody else. And you can see here when we see progression-free survival that for exon, when we focus on patients with c-KIT exon 9 mutations, we can see a clear benefit when we used 800 versus 400, while there is no difference for everybody else. The same for the overall survival. Exon 9 is doing better with double the dose of 800. So based on that, actually, now we know that for patients with c-KIT exon 9 mutation, this is the one exception to the rule of 400. For this patient, we like to give 800 milligrams of imatinib. Here I have another slide about the trial that approved sunitinib. These are patients after failure of Imatinib, and you can see here that sunitinib compared with placebo has a clear benefit for progression-free survival and also overall survival. This is a study that approved regorafenib. Again, this is versus placebo. And in this study, you can see that the median progression-free survival was 4.8 months for regorafenib versus 0.9 months. So not clear difference when we talk about overall survival. So then we have two agents that have been approved recently. Avapridinip is the one that was approved in 2020 for the PDGFRA exon 18 mutations. This is a very, so the D842V mutation is included in exon 18. This is a very resistant mutation, very resistant to Imatinib. Actually, before this approval, we used to use dasatinib for that. So the overall response in this patient was quite impressive, was 84%, with complete response of 7% and partial response of 77%. And when we focus on that mutation only, it's even more impressive. The other events of this drug is edema, fatigue, abdominal pain, some cognitive impairment, but nothing very severe. Then we have the other drug that was approved also in 2020, approved as a fourth line. This is not specific for specific mutations. The overall response rate was 9.4 versus 0% for placebo. Actually, here we have a couple of side effects like increased cutaneous malignancies, like 4.7%. Also, there's an increase in melanoma, 2.4, but otherwise it is a very well-tolerated drug. And these are the data from the trial, the Kinlock trial that approved the drug. You can see here the 6.3 months progression-free survival versus one with placebo. So, and this is the overall survival, 15.1 months versus 6.6 months. So I'm going back to the slides about genetics, and I want to focus again to these groups of wild type, what we used to call wild type GIST, that we don't have great treatments. So actually, the treatment for these rare types of GIST can be very different. Again, this is a slide about the hereditary GIST syndromes. And this is actually another diagram showing how we categorize the GIST. So the two big groups are the c-KIT and PDGFRA mutant GIST. On the one side, usually those respond to Imatinib. It can be sporadic or familiar. And then we have what we call c-KIT PDGFRA wild type GIST, and we have the STH deficient GIST that can have mutations or no mutations. Now we know that they have methylation in SDHC, and the SDH mutations can be either sporadic or can be germline, and the patient have Cardinality Syndrome. And the patient with SDHC methylation, they tend to have Cardinal Triad disease, the triad of GIST, paragangliomas, and chondromas. So then we have the non-SDH deficient GIST, and we can have other mutations, NF1 or BRAF, and we can have actually, there are more other terminology now being used for this type of GIST, which is non-SDH. I think, Sarah, we're calling them quadruple GIST. right?
Quadruple wild type GIST.
Right. Right. So there is more categorization. So in 2007, actually, we were able to identify at NIH that there is a type of GIST, which is the pediatric type, that actually is very different. 85% of GIST is like a mutation in c-KIT or PDGFRA. We know that these patients have location of the GIST in the stomach primarily. They have more epithelioid histology and multifocal lesions. And it may be syndromic, either the Cardinal Triad or the Stratification syndrome. These have SDH deficiency by immunohistochemistry. And we knew that actually these patients do not do well on Imatinib. Actually, 2008, this is from Dr. Stratakis' lab. So we were able to show that these patients have germline mutations in SDH, B, and C, and D, which is part of the Krebs cycle in mitochondria. So a few words about the syndromic SDH GIST. So we have two syndromes. The one is the Cardinal Triad. These patients have multifocal GIST, as you see here. They have paragangliomas, and they have also chondromas in the lung, which are benign lesions. And then we have a separate inherited syndrome, which is the Carney-Stratakis syndrome, that they do not have chondromas, but they have the GIST and they have paragangliomas. So this is work at Dr. Meltzer lab at NCI, showing that when we compare this, the c-KIT or PDGFRA mutated GIST, which is this area, with the SDH deficient GIST, so the DNA is heavily methylated. And I'm sorry about the terminology. This is very scientific, but this knowledge from high school and college. So in DNA, sometimes the genes are not working well because the beginning of the gene is being covered by what we call methyl groups, and this is what you see here. So we knew that this rare type, the SDH deficient GIST, actually can be heavily methylated, meaning that many genes do not work properly. And here you can see the traditional GIST, the c-KIT and PDGFRA that has it has actually intact SDH staining. So this actually this is a study that is called comparative genomic hybridization, that we match the DNA of the patient with a normal DNA, and you can see that there are many discrepancies. And this is the DNA from a patient with SDH GIST, that actually you can see that they don't have many genetic defects, except that the one with SDH mutation. So based on this study from Paul Meltzer and Lee Hellman labs, we know that actually the c-KIT PDGFRA mutated GIST is very different than the pediatric GIST. This is a graph explaining what is going on. This is actually the tetramer of the succinate dehydrogenase complex. And this is the mitochondria, which are the factories of energy in the human cell. And when this doesn't work, when we have mutations in this complex, there is a release of this metabolite, the succinate, which is going to the cell in different areas like the cytoplasm or the nucleus, and it is causing the methylation, the silencing of the genes. And these are actually the data showing that a small subset of the patients didn't have mutations, but they have methylation in one of the subunits. and in the SDHC. And actually, this is a very different group of people, because we're going to see in this graph here, when we summarize the data from NIH, we realize there are 3 groups of c-KIT and PDGFRA wild-type GIST. These are some concentric cycles having different data. The outer cycle is about staining of SDHB. So this is the SDHB intact, and this is the SDHB mutated. Deficient. What we call SDH deficient GIST. Then the second cycle is the global methylation. This is normal methylation, like in normal cells, but the rest in group B and C, we see that they have hypermethylation. So many genes are not working well. And then on cycle 4, you see mutations. These are mutations in SDHA, B, C, and D. In group C, we have methylation, so silencing of the gene in a different way of SDHC. And then in group A, we don't have any impact on SDH mutations, but we have several other genes like NF1, BRAF. Actually, these are other small separate groups that every single of one has very specific treatment. The lesson from that graph is that pretty much genetic testing is very important, because we treat very differently all these small subgroups of GIST. And genetic testing is the foundation, not only for treatment and follow-up, but also for genetic counseling in case it is germline and in case families have the same disease. So by saying that, what are the differences in treating these cases? So SDH deficient, we know now that it doesn't respond well to Imatinib. So usually we don't use Imatinib in these patients. We use sunitinib or regorafenib. There is also a temozolomide trial. For BRAF mutated genes, actually they tend to respond to BRAF inhibitors like the vemurafenib that we use in melanoma. NF1 and RAS, they don't respond well to Imatinib. We tend to put them on Imatinib, and because they are slow growing, we feel that it keeps the disease stable, but there is no evidence that Imatinib has any role. I have to say that there are some data for MEK inhibitors in NF1 tumors, but we don't have sufficient data for NF1 GIST. But this is something that can be tried. Overall, NF1 GIST, once they are resected, usually they don't tend to recur, often. If they have a P13K mutation, we can use a mTOR inhibitor. We have actually some families, some patients published recently with NTRK fusions. We have now very good drugs that target this fusion. And for c-KIT resistant mutations, for exon 13, we use sunitinib. For exon 17, we can use regorafenib or imatinib. This is the stratification, that different ways to stratify the risk of GIST. Dr. Adrafai mentioned previously that we use actually that a lot to predict the behavior of the GIST and to decide actually on adjuvant treatment. Actually, I tend to use the Imatinib criteria a lot. It's a complex table, but actually I have summarized on this table what are the criteria to use adjuvant Imatinib after resection of a GIST with high-risk features. So tumor rupture is always a reason to put somebody on Imatinib. High mitotic rate, more than 5, is also another reason to put somebody on adjuvant Imatinib 400. And when the patient have low mitotic rate, then we use the size as criteria. So if they are in the stomach and they are more than 10 centimeters, we use adjuvant imatinib. And if they're in the small bowel and the tumor is more than 5, we use again adjuvant imatinib. So to go back to Dr. Alrafai presentation, if I remember well, he mentioned one patient with 4.5 centimeter size and high mitotic index, meaning more than 5 mitosis per 50 high power fields. So in that case, we would use adjuvant imatinib. And the question is for how long? So there are 3 trials actually that have looked in the past regarding the duration. And there are more right now as we talk. This is the first trial here showing that patients on 1 year of imatinib versus placebo are doing much better. The recurrent-free survival was 98% versus 83%. So initially, adjuvant imatinib was approved for 1 year. Actually, here there was in the same trial stratification based on high-risk features. Here we have less than 6 centimeters. Here we have between 6 and 10. And here we have size more than 10. And you can see that the benefit is much higher when we have a larger size of the tumor. So now we know that patients with intermediate risk and high risk, based on the Miettinen criteria, they need to be on adjuvant imatinib for at least 3 years. And actually, this is the trial that compared 3 years versus 1 year of imatinib, and we know that 3 years is better. And there are ongoing trials actually having patients on for more extensive time than 3 years. So to summarize, surgery is first-line treatment for resectable GIST. So mutation analysis is the foundation of how we treat and follow the patients. Imatinib for recurrent unresectable metastatic GIST provides prolonged disease control in most of the patients. Imatinib 400 is the standard dose, and we consider 800 if patients have exon 9 mutations. Sunitinib is the second line, and regorafenib is the third line. Ripretinib is the fourth line right now. Imatinib 400 milligrams for 3 years is the currently FDA-approved duration for high-risk patients. And adjuvant or neoadjuvant therapy with imatinib is always under consideration. We have cases like difficult resection of the G junction, etc. Avapridinip is the 5th drug that was recently approved for PDGFRA exon 18 mutations, including the D842V. And I have to say that it's always important to be enrolled in trials because there are always new exciting things. So we're trying to bring trials at MedStar for GIST, and we're going to have one in June 2022. So I would like to thank, actually, a great thanks to the NIH Clinic that has done this fantastic work all these years, and all these centers. We are part of this clinic. For rare tumors, collaboration is the only way. And actually, a great thanks to LifeRaft being supportive all these years for the GIST clinic. And then a great thanks to our multidisciplinary clinic at MedStar. So it's very important to have continued collaboration between different disciplines. And I'm grateful for all their support. Thank you very much. And please let me know if you have any questions.
Wonderful. Thank you, Dr. Boykas. Are there any questions? I see a few questions here in the chat. just giving everyone a chance to speak. And if Dr. Boyko, so if he can stop sharing, I don't think I can.
Oh, I'm sorry. I apologize for that.
No, it's okay.
Actually, I'm trying. I have minimized.
On the very bottom bar where it shares share screen, if you just click that and hit stop sharing, it should go from there.
I think I did it. Am I still sharing my screen?
So I'm just trying to. There we go. There we go.
Okay.
Excellent. Excellent. All right. So just looking at the questions being asked here is starting with, if the stomach, just along with some localized liver lesions, are resected and treatment with Gleevec is provided before and after the resection, is there a good chance that recurrence can be prevented? Who would like to answer that question?
Our surgeons.
Yes.
Dr. Stevies, do you want to take it on?
Yes, so basically the question was, primary's been resected, now had synchronous liver lesions, or there's a period of time in between? Well, it doesn't matter. After complete surgical resection, there is a possibility that this disease has been taken care of. Patient needs to stay on Gleevec, and there is a risk of recurrence, but certainly if it has favorable exon mutation, then there's a potential that could be cured. We have seen some people get cured with metastatic disease that we've resected. Again, the key to this is the metastatic disease needs to be resected. Eventually, metastatic disease that is not resected will not respond for a prolonged period of time to tyrosine kinase inhibitors.
My take on it, if I may, the risk of recurrence obviously is higher with someone who already have liver metastasis, but there are a couple of things to think about, as Dr. Stevies mentioned. If it's small and one liver metastasis, for example, that has been resected, that's more favorable. If the patient has responded to targeted therapy, that's favorable as well. If the timing between where the primary happened and then the metastasis later on is prolonged, that's also favorable. But I think with the presence of multiple targeted therapy and the aggressive surgical approach, the chances for prolonged disease-free interval is actually not surprising.
One little comment I want to make is that when we have progression, it's useful sometimes to repeat the mutation analysis just to see if there is any resistant clone.
And I agree with that, and I'm glad you mentioned it, Dr. Boykas, and it's probably a underestimated tool to be done.
Yeah.
Great. Thank you. If someone had a germline GIST and one parent had genetic testing, which was negative, is it certain that the GIST was inherited from the other parent, or could it have been a sporadic development in the patient's germline?
So unless we check both parents, we cannot know for sure. There are patients that they have what we call the Novo Mutations. I think it's called it is called here sporadic development. It's not sporadic development. It's a de novo germline mutation that when we're born we have bad luck and there's a defect. So it can happen to have both parents negative mutation and only the patient to have the germline mutation. It is possible. But of course, both parents have to be checked.
Okay. Thank you.